My name is Simone.
Yoray.
I'm Asya.
I'm Elise.
And I'm Yoray.
And today we're discussing enabling access to reproductive healthcare for Appalachian women. In this presentation, we will go through the context, access to healthcare, stigma, teen pregnancy, and then two possible solutions: transportation and telehealth.
So, located in the eastern United States, the Appalachian region consists of in the Appalachian Mountains and consists of 424 counties and 13 states, some of which include Alabama, Mississippi, Kentucky, and Georgia. The Appalachian region is home to over 25 million people, of which 42% are from rural communities. According to Partridge and colleagues in American Journal of Agricultural Economics, the average poverty rate in Appalachia exceeds 30%, which is more than 2 times the national average. The poverty rate is worsened due to low-paid jobs, less educational access, and weak local governance in the region. The measure of income inequality has hit its highest since 2017, and this affected healthcare access for vulnerable populations such as women and children. According to Swan et al., 47.5% of women reported that they don't have any access to women's clinics or family centers close to them. This limits their reproductive autonomy, puts them at risk for unhealthy pregnancies, and also increases sexually transmitted diseases and cancer rates in the region.
David Dry, a researcher at the University of Kentucky, found that in many areas of Appalachia, women have to travel between 30 to 50 miles to access obstetric care. For context, this would be like if a woman in Palo Alto had to drive all the way up to Marin to access healthcare.
So this begs the question, how can the lack of access to women's healthcare in Appalachia be mitigated?
There are a couple of factors that contribute to this lack of access to reproductive healthcare in Appalachia. And one of them is cultural stigma, which is largely influenced by the high percentage of people who are devout Christians in Appalachia. According to Caitlin Barker, 3 out of 4 Appalachians are devout Christians, and it plays a large role in shaping the opposition to sexual health education in schools. This is organizations such as the Concerned Women for America and the Christian Coalition, for example, push for an abstinence-only sexual education policy because they think it supports family values. However, this is not really effective because it leaves a lot of vulnerable youth and women without the resources and the information they need to access that healthcare. Additionally, abstinence-only healthcare has not been proven to work, as a study by researcher Jeremy Dalton found that Appalachian teens are open to using contraception and are open to learning about safe sex practices, regardless of what the adults try to teach them in schools. Additionally, this means that women later in life also just generally, when you don't know about something, you have fewer options for support. And women in Appalachia are less likely to receive screenings for breast cancer, HPV vaccinations, and testing for STDs.
So a combination of the cultural stigma that Elise defined, as well as lower educational and overall attainment in Appalachia, contributes to a cycle of teen poverty and teen pregnancy. According to the Appalachian Regional Commission, pregnant teens are more likely to drop out than in Appalachia than in any other region in the United States. And this is due to the fact that they would like to stay at home and resort to their family values and remain with their children. However, this limits job opportunities for Appalachians. And this leads to more working hours in their schedule, which leads to dysfunctional relationships between parents and children. According to Betsy Dalton, a researcher at University of Tennessee, Knoxville, Appalachian children feel rejected from their parents, and as a result, they turn to sexual relationships to receive love and affection, which they do not receive within the home. And this perpetuates a cycle of pregnancy and poverty, in which the children of these teen parents do not receive the same love and affection as did their parents not receive the same love and affection from their parents. and as a result, they turn more to sexual relationships. With the fact that they do not have the same educational resources as other people in the United States do, they do not have access to contraception and overall care. So the best way to break the cycle would be at that red point right there, improving access to discrete measures of contraception. By improving that, we can effectively break the cycle right where a teen has sexual relationships and also right before a teen gets pregnant. And this will also effectively avoid the cultural stigma that can be perpetuated by a lot of parents and the coalitions that Elise had defined that promote no contraception and a poor sexual education, abstinence-only sexual education within schools.
As Simone discussed, the main problem here is a lack of access to healthcare, and one possible solution could be transportation. According to Dr. Bailey from the Journal of the Poor and Underserved, this could be in forms of shuttle services, non-emergency medical transport, and rideshare companies such as Lyft or Uber. According to Kentucky State University, a small study was done where transportation was given to women in a rural area in eastern Kentucky, and it showed positive results because the main problem is the lack of transportation to these health facilities. So by giving women opportunities to travel to these clinics, they can effectively increase access to reproductive health care.
However, this comes with a significant limitation. Improving access via transportation does not negate the fact that women are still having to travel between 30 to 50 miles to access this care. So while it is easier for them to get there, it's still an incredibly long distance. This brings up our solution of telehealth.
Yeah, so instead of bringing Appalachian women to the healthcare, we should focus on bringing the healthcare to the people. And we can do this through telehealth. So telehealth is a robust online system that allows Appalachians to access healthcare through one-on-one calls with their doctors and ordering prescriptions online. From the comfort of their homes, telehealth includes communication technology that allows patients to discuss any sexual education and contraception measures with their with their healthcare providers. They can do so through pre-recorded videos, mobile apps, and video calls. A study from the Journal of Telehealth and Telemedicine confirmed that Appalachians have saved an average of $260 in healthcare through telehealth. Overall, telehealth promotes accessibility and affordability, which are both key for rural Appalachian women.
Of course, the solution does not come without limitations. One important factor that determines the quality of healthcare is your ability to diagnose and provide prescription drugs and lab results, and that's hard to do online, especially when medical lab testing is needed or you need a physical examination or something. Luckily, there is a solution to help mitigate the effects of that, and it's called Dispatch Health, which is it can be modeled after a program called Dispatch Health, which is a program that partners with telehealth to come to patients' homes as needed, and that helps with diagnosis and can help people receive the drugs they need to combat their illness or whatever health issues they're having, and it is a good hybrid model that still addresses the transportation barrier and also helps people be examined in person. Dispatch Health as an organization has, since its founding, served 1.2 million patients nationally and has in more than 20 states. And this is an increasingly possible solution as, according to the Appalachian Regional Commission, more than about 90% of Appalachian homes have access to a computer, and about 84.5% have access to a broadband internet subscription. Access to women's healthcare in Appalachia is a significant problem. Transportation is not a viable solution for this particular problem due to substantial limitations, but telehealth, specifically as it pertains to dispatch care, has shown to be a potentially promising solution.
Okay, thank you. We're going to go straight into the oral defense. So let's see, I'm going to start with Asya and go this way, okay? Hold on 1 second. So Asya, first question is Asya, give one specific way that your thinking changed as a result of learning about Carolyn's findings.
Yeah, so Carolyn's findings focus on the neonatal abstinence syndrome, which is, and also opioid use in Appalachian women. And I got to learn a lot about the scientific implications that lack of access in Appalachia causes. And through that, we get, so Caroline gave us a solution that we should, think about transportation and as a physical solution. So that's when we came up with the idea to put it as a possible solution after we discussed the limitations. And yeah, so Caroline's approach really helped us gather the scientific and implications and the importance of addressing this issue, considering this healthcare.
Okay, thank you. Yoray, how did the group decide to use Simone's perspective into the overall presentation?
So we decided to use Simone's perspective through her research on teen pregnancy, and as you can tell, one of the slides was about teen pregnancy, and this teen pregnancy helped me and our group learn how the cultural background to Appalachia and also the stigma and the reason why there's such a lack of access and how it affects the women and children who live in Appalachia.
Okay, thanks, Yoray. Carolyn, having finished your project, what, if anything, do you consider to be a gap in your team's research that, if addressed, would make you feel more confident about your solution?
Something that I think we could have focused a little bit more particularly as a limitation was the prevalence of domestic violence in Appalachia. That's something that Elise actually wrote her whole IRR on, and that is a pretty significant limitation. Women may not be able to leave the house, and even for telehealth, it may not be safe for them to be receiving that kind of health care in the home. So I think further research on the accessibility of women's health care for women in abusive relationships would have been helpful.
Okay, thank you. Elise, what is a way in which your team's solution makes you think differently about your own IRR?
So kind of jumping off what Carolyn said, I think I hadn't, mine was obviously about domestic abuse, which is related, but didn't integrate quite as much into the presentation. And thinking about how I was thinking more when in my paper about kind of like ways to support survivors and victims in a way that was more like physical and like just increasing access to medical centers. And I was also originally just thinking of transportation. And Asya was actually the one who, her IRR went really deep into like telehealth as a solution to a lot of health issues in Appalachia. And it made me realize that like a lot of course domestic violence is not entirely addressed through telehealth, but it helped me think of more like different formats of solutions and of more like just different more creative ways to help people in Appalachia, because I was definitely thinking about it as more of a you go here, this is how you get help, but there are really a lot more creative ways to kind of get solutions to people who need them.
Okay, thank you. And Simone, in the future, what change would you make to your group norms, and how would you expect that to improve your team presentation?
So our group, we had a lot of different ideas in terms of our IMPs, what we had an idea for in terms of our roadmap. So I think some of us had an idea where we should put our research question up first and then explain some of the context later. So a lot of our context surrounding the Appalachian region, what it consists of, what are the cultural barriers, was placed originally after the research question. But as a group, we came together and realized that in order to make this the line of reasoning of our presentation as clear as possible, we need to put all this background information surrounding cultural stigma earlier, and then have Elise's section about cultural stigma, and then my section about how it came to be after. And that, I think, effectively really helped our presentation overall. But what I think we could have done is really gone over our structure earlier and really defined what we could have done, because we were more in kind of a panic when we realized that our line of reasoning just wasn't very clear. So by being more clear about what our
Mhm.
You know, what should go first? How can we attack this sensitive issue so carefully, such that we don't, you know, make any overgeneralizations with
Mhm.
explaining the cultural background of the region? That was really important for us.
Okay, ladies, you are done.